Hello everybody and welcome to our second Members Week event. Thank you for joining us. It was great to see some of you last night as we had the presentations on robotic innovation and artificial intelligence in healthcare. My name is Dan Bishop. I am one of the public governors at the Royal Surrey Foundation Trust. I'm in the Guildford constituency and I thought I'd start by just telling you a little bit about how I've come to be here. I've been very passionate about the NHS for a while now. Having been a patient at the Royal Surrey for the last 5 years in the oncology department, and now I am a public governor, as I mentioned. So I've experienced firsthand the really vital work that this hospital is doing, and I'm delighted now in my position as a public governor to be able to work with the members and the public more about the wonderful work that the hospital is doing. This is a wonderful opportunity we've got this evening to hear some fantastic presentations from some of the people who have been working on the front line during the pandemic, and I will introduce you to our speakers in just a second. As we know, technology has been really vital in helping the hospital manage the overwhelming pressures placed on its services since the start of the Covid-19 pandemic. Everything from specifically designed smartphones and how important are they these days, to conducting virtual ward rounds with using video conferencing and remote appointments with GPs and other clinical teams and patients. Before I introduce our first speaker, I'd just like to remind you at home that you can submit questions at the end of our presentations, and we'll have a Q&A session where I'll invite the speakers to answer the questions that you sent in. So to do that, you can use the chat feature on the Teams meeting. Simply just type your, click the question icon, which will show the chat box saying Q&A. You can type your message in there and click the send icon, and that will send your message to us, and we will ask whoever is most appropriate to answer it for you. So it's now my great pleasure to invite Jennie Price, who is our Associate Director of Operations for Diagnostics and Clinical Support Services, to talk to us about the innovative COVID testing operations which were introduced during the pandemic. Thanks, Jennie.
Good afternoon, everybody. Thank you for having us here. So I'd like to talk to you about some of the innovation that we've made with our COVID testing services over the last 18 months. Back in March 2020, when we started testing for COVID, it was often quite frequent we would wait 3 days before we got a test, as tests were sent across the southeast of England to a variety of laboratories. This improved dramatically when we installed our on-site laboratory, which brought our turnaround time down to 24 hours. But actually, this was still quite challenging operationally to manage. It meant that it still took over a day before we'd be able to give patients access to a diagnosis. And actually, what our point of care team did was they took up the mantle on how to improve 3 things for our patients and our services. 1, they wanted to improve the speed that we could test for COVID. 2, they wanted to increase the capacity of COVID tests that we could perform. And 3, really importantly, they wanted to install testing capacity in the hospital in the areas where we're delivering clinical care. And I'm going to hand you over now to Katy Heaney, who's one of our consultant scientists, who's helped lead the innovation of these services for our hospital.
Good afternoon, everybody. My name is Katy Heaney. I'm a consultant clinical scientist for Berkshire and Surrey Pathology Services and the cross-site lead for point-of-care testing across 4 trusts, of which Royal Surrey is one. Point-of-care testing is defined as any analytical test done outside of the laboratory by a healthcare professional. Our aim is to provide rapid testing at the point of need, where the patient is. So a lot of our devices are based inside the accident and emergency department in A&E or in ITU for our most critical patients, or maternity or the neonatal unit, for example. Point of care testing is a really critical part of Berkshire and Surrey's pathology service. It's been the focus for the last 20 years to recognise the need for rapid tests to make rapid decisions, and management of our patients requires that result to be there as quickly as possible, but also to be of high quality. When COVID-19 reached England, the pathology community stood up our ability to do testing as quickly as was manageable. This was in line with UK and global limitations on the availability of equipment and reagents and chemicals. But what we felt as a rapid COVID testing service is that we needed to be ready for when that technology was available to us to provide rapid COVID testing service within the A&E department. So we made a plan. That plan began with where would we do that testing? So what would we need in the room? What benching would we require? What computers would we require? All the PowerPoints that might be required for multiple different analyzers that would be there with us to provide the tests. How would we staff the service? So we thought about the number of staff we would need in order to run a 24-hour, 7 days a week service. We thought about whether those staff members would be nurses, would they be healthcare assistants, or would they be laboratory staff or very junior staff, new into the profession. And ultimately, we had to consider who was available to us, as at the very start of the pandemic, there was a huge NHS staffing crisis and we needed to bring as many people in as possible. And the last part of our plan was how we'd report the results. Rapid results are most useful when they've made it to the electronic patient record, so that everybody can see what those results are, and ultimately so that we can report them back to Public Health England, so that they're able to monitor the amount of COVID within the country. So we made this plan and we got ourselves ready. And on a Friday evening in April, I received an email just as I was about to shut down my system that offered us from the Department of Health the opportunity to trial out the first rapid testing equipment that was available to our services. And frankly, we said yes. We felt that this was an opportunity we couldn't turn down, that we had to do our part on the national effort to look at whether these devices were suitable for A&E departments and what kind of difference they would make to testing in a hospital. So we began work in the phase 1 pilot, on the first slide please, of the DRW Samba. Diagnostics for the Real World is a company based out in Cambridge. They've been producing the device, which is called the Samba 2, for some years now. However, it was not used inside the UK or the NHS. It was used in Africa and used for HIV testing in very remote areas. So they had produced a test for COVID, but nobody really knew operationally how that would work within an NHS setup and how it would work with A&E. So in the photograph you can see now on the left-hand side, that's our first laboratory for point-of-care testing for Samba for COVID in Royal Surrey department. Dave Bulch there is our point-of-care site lead on the left, and Emma Hottinger was one of our new members of staff we hired at the time. We had to hire ultimately 40 members of staff within the space of 3 weeks in order to set up the services across our 5 acute hospital sites. We kitted out the rooms, we built them from scratch. Quite an unusual thing to happen in a hospital service, to walk into a room and repurpose it within 24 hours to move it into something else, but it happened. And then we also had all of the IT build we'd already planned and were able to implement in a rapid way. So between that email on that Friday evening to the go live of our first service was just 3 weeks. We were able to start up that testing and get it moving for our patients. And I must mention, critical to that was Becca Sharkey in the middle of that picture as one of our virology point-of-care testing leads in her jazzy scrubs, as ultimately those were the scrubs available to us at the time. So on the 18th of May, we went live with our first A&E service, and over the course of the following 4 weeks, we went live with a different hospital site every week in order to start providing 24-hour testing. The sad part of that was that ultimately the reagent available to us for testing was still very limited. We were only able to offer at the time 24 patient tests in a 24-hour period, which in comparison to an A&E department's admissions was really not good enough. So we grew the service, and as more reagent became available to us, we were able to improve the number of Sambas, improve the number of devices, and to the point where in October 2020, we were actually able to offer 100 patient tests within a 24-hour period. To give you some context over this, as Jennie was saying, the laboratory services were able to get their tests back within a 24-hour period, On the Samba, we were able to give a result in 2 hours. Still not as good as we'd like, but it was far better, and it just kept improving. News of our success travelled, and the Department of Health team requested our service to produce a template on how to use the DRW Samba across other NHS sites. So we made videos to share that with our pathology colleagues. We made what's called standard operating procedures, step-by-step guides about how to implement these devices, how to start using them, and how to make them the most efficient service for your A&E department. Our expertise was relied on further in December 2020, when another device came onto market and came into the UK for COVID testing. So on the next slide, you can see here the Roche device. This was a device we already had in use at the Royal Surrey for flu testing during the flu season. And we were given the opportunity to have the first batch of reagents for Covid-19 when it came into the country, and were able to then provide the national scientific advisors with performance data about how good this test was. This test was able to give a PCR result in just 20 minutes for COVID. The numbers were very small, and initially we only were able to give out 10 per day to the A&E department, but for the most critical of patients, this was a huge bonus. The service has grown again, and we are now in a position to offer 60 of these 20-minute tests per 24 hours to our services, almost covering all of the A&E patients who get admitted within a 24-hour period. As a combination now of our service, which has both the Samba and the Roche in, we're able to offer 180 patient tests per 24 hours in order to support not just A&E now, but also urgent surgery, maternity admissions, and rapid discharges if they need a test before they leave our site. To add further to our service, in March 2021, we were offered the next device. This is the Lumira DX. It is a Scottish-based company. The test is a rapid antigen test. It performs far better than the lateral flow devices, so we were able to give a test result on this in just 12 minutes. And by doing a combination of antigen and PCR testing, able to give our infection control teams a better understanding of whether the patient had just contracted COVID-19 or whether it was perhaps a past disease. I'm extremely proud of the work that we have done on rapid COVID testing, both locally at the Royal Surrey, but also in our national response. Our assistance with the DRW Samba and the template we were able to offer other NHS sites has now resulted in the rollout of almost 1,000 Samba devices across 96 NHS England sites. We led the national evaluation on the Roche Liat. There are now 155 of those in use across NHS England at 43 sites. And we also assisted in research studies looking at brand new kit coming to market to see if it was suitable for any more of those services. And lastly, in December 2020, in recognition of the work that we had done, I was asked to second myself to the Department of Health as the rapid COVID testing lead for operational supplies. This meant I had responsibility now for all of the NHS England and the devolved authorities. Rapid COVID testing devices. This is over 2,000 devices on 190 sites. I look at the efficiency of those devices, the services they run, and liaise with the manufacturers to make sure that we have the right technical information on those tests. We're extremely proud of what we've done locally and nationally. I hope you've enjoyed hearing a bit about how our service has grown here at the Royal Surrey and the ability of ourselves to support rapid COVID testing for any patient that comes into the Royal Surrey Trust. Thank you very much, and I shall pass back to Dan.
Well, thank you so much, Jennie and Katy, for those really enlightening presentations. And I'm sure many of you at home will be thinking the same as me, which is that, you know, we have these COVID tests and they go up and we're never quite sure where they go to, and then the results come back with a text message or an email or something like that. And it's really insightful to hear a bit about what happens along the way, and also the steps that the trust and the pathology services have been able to take to improve those times across the pandemic. In a minute, we're going to hear from Dr Justin Kirk-Bayley, who is the clinical lead for intensive care here at the Royal Surrey. But before we do that, we're going to watch a short video where you'll be able to hear from two of our patients who were treated by Justin and his team, his wonderful team, when they contracted COVID during the first wave of the pandemic. So let's watch that film now.
I contracted COVID-19 towards the end of March 2020, and only less than 24 hours, my conditions deteriorated really rapidly. I was immediately taken to the hospital by ambulance.
My name is Joanna. I was admitted to hospital in April with COVID and double pneumonia. I had actually been at home for 2 weeks self-isolating, so when I got into hospital I was really seriously ill. I left in June. I started off in the emergency assessment unit for 2 weeks, but then I deteriorated.
I've got no memory of what happened after my first day in the general ward. Since my wife has told me soon after my breathing deteriorated, she said, you told me that, don't worry, everything's fine, God is in charge, and I'll see you soon. After that, I had to be admitted to the intensive care unit and placed on a ventilator.
The rest of it becomes rather a blur. I was put in a coma, and then obviously moved to ICU.
I spent 5 weeks on ventilation in the ICU department, and I'm told I was woken early in May 2020. But after that, it took still over a week for me to wake up properly from my semi-consciousness and start to recognise my surroundings and become fully aware that I was at Royal Surrey.
My time in ICU, I was semi-conscious, I would say probably 2/3 of my stay. And I lived in a land of hallucinations. Unfortunately for me, they were rather frightening.
There are some experiences which I can only describe as dreamlike hallucinations because I've never had hallucinations in my life, but at the time felt very real.
I was with aliens and I thought I'd been sold for medical purposes. I think this was because the nurses and doctors were dressed, of course, in their PPE, because I was in an isolation ward. It was a COVID ward.
There was something about people having had COVID who'd been really ill that actually a lot of the time this delirium and the symptoms that they experienced were really quite severe and very difficult to manage.
I was running with a pack of prehistoric animals, strange animals which looked like dinosaurs, but they were very clever.
On the changeovers between the nurses every 12 hours, they always discussed your case. I listened to this because my hearing was very acute. They seemed to know far too much about my history. Again, I didn't really trust my nurses at that point, and although they were trying to comfort me, it didn't seem to work for me.
When recovering from critical illness, one of the things that people often experience is something that we call delirium, where they aren't processing the world around them in a normal way, and they often experience hallucinations or delusions in a way that Joanna remembers from her time in intensive care.
A temporary state of confusion is very common in people admitted to an ICU. It's also not unheard of for people to become so disorientated in critical care that they become confused about what doctors and nurses are trying to do to help them.
I immediately recognised and realised there was something around my throat stopping me to breathe, and eventually felt being strangled. The nurses were very loving. They held my hands. They said, look, don't worry, it's fine. This is a special device to help you breathe. You don't need to be worried about it. You will get used to it. And basically that was the oxygen I needed to stay alive.
It's important to emphasise that these symptoms are likely to be part of their illness. Confusion is a temporary state and almost always resolves as the patient's physical health improves.
When in the last 2 weeks I came round in ICU, gained consciousness, my days were filled. I suddenly enjoyed and appreciated the love and care of the nurses, and I looked forward to seeing the doctors, who were very patient about explaining my progress.
The nurses and doctors kept reminding me about where I was in a safe place, and the date and the time, who was looking after me, the name of the nurse, but I felt that they were very compassionate and loving towards me, and I felt very, very comforted by this. I'm so grateful to for all the help I've received, for all the wonderful angels at Royal Surrey, all the health professionals, all the ancillary staff, even the cleaners who were amazingly kind and gracious to me.
Thank you so much.
Well, thank you for bearing with our technical issues there. Thank you to the amazing technicians in the room who overcame them. A massive thank you as well, obviously, to Sam and Joanna for sharing those really powerful stories. And we're now going to hear, as I said, a bit more from Justin, who is the clinical lead for intensive care, and also Claire Richardson, who is one of our clinical nurse specialists. They're going to share with us how they had to adapt and embrace virtual technology during the COVID pandemic, and how it was used in intensive care as well as on the wards to bring people together. This technology has been absolutely instrumental in assisting communications between clinical teams and also between patients and their relatives. It's been a bridge for patients to bring them together with their relatives, as I said, and those have been really difficult times, as we all know, so that's been a really vital link. So over to Justin and Claire.
Hello, I'm Justin Kirk-Bayley. I am the clinical lead for intensive care here at the Royal Surrey, and you've just seen some pictures of my intensive care unit. I'm hoping that few of you have ever seen the inside of an intensive care unit. It became quite apparent, as of course it did to everybody, that at the beginning of the pandemic, what we had to do was to isolate people with COVID. Now, intensive care is like many other wards in that we run ward rounds. We have gatherings of doctors and nurses and dietitians, pharmacists, and we gather around the patients and we talk about them and discuss things to get them better. The problem with that is that we needed to keep these people with this highly infectious virus away from everybody else. So we had to have a solution so that we could get communications going, but also protect our team. We started out in the beginning by using walkie-talkies so that we could communicate from people from within a room. We had somebody on a screen, ideally, but actually we didn't have a patient on, we didn't have a person on the screen, we just had the notes because we're on an electronic note system. Now, a friend of mine who works here, who's behind the camera today, Andy Dog, you'll see a photo of him later, and I had worked with a company called Ascom, and they have a device called a Myco. It's a bit like a smartphone, a bit like your Android or your Apple device that might you use every day. And what this is just like a smartphone. It has a two-way video camera. It's got software that we've come to know and enjoy, and it allows us to use that. And use that we did during the first and the second waves of the pandemic as I went through, to be able to project things up onto the screen where we gather all our ward round people into a room. And we could have a look at the person who was using the device near the patient. There's a picture I put together with me, or I'm not in full PPE. And this is exactly our day-to-day life with dietitians and nurses discussing the patients and looking at what's going on. We could point it at ventilators, and then we could switch through to our electronic nose system. The device is fantastic because it's got a history behind it used in industry and warehouses and shops and things like that, and it meets all the criteria that you need. It's infection control compliant, and the system that we managed to put on it is information governance compliant as well, so that we can make sure nobody else could get to it, and we very rapidly realised that we could get rid of those walkie-talkies. Now, the staff liked it a lot because it was very, very easy to use. And we grew with it as well. We found more and more ways of using it. The nice thing about it as well was that we found more ways to use it in clinical times. So we're able to interface with people even outside of our intensive care unit too. For example, on one occasion we had a patient who had a nasty rash, and you may have even seen the news today that COVID caused a rash on people's toes and various things like that. And we didn't know what it was because this was right at the beginning, and we were able to actually show people. And we showed a dermatologist and said, "What's this?" And they were one of the first people like us to see COVID rash, and they were protected outside the hospital, and we could liaise with them. And it was really good. And we were able also, and as Claire will say to you, we were able to do things with speaking to patients' relatives as well. And when patients got off their ventilators and they got better, we were able to get them to talk to their loved ones whilst we were still looking after them, whilst they were awake with us, but weren't well enough to be able to leave the intensive care unit. During the pandemic, at the height of it, you may have heard Matt Hancock, the Health Secretary, talk about this thing called the bleep that we have in hospitals. Cast your mind back to the early 1980s or before with the pager system where it just projects a number up on a screen. Well, that's a system that's used very often in data work today in hospitals, and that's how we communicate with each other. But there's no doubt that this MyCom device or ASCOM's got a lot more potential to it, and we really found something that could potentially be fit for the future. So this may well be, as Matt Hancock said, the death knell to the pager, to the bleep in the hospital. We are only at the beginning because this is really fit for the future and we could do so much more with this. And we were recognised in being able to develop this and do things in an award that we won. And here's a picture of Andy Ring showing the award, and it was entitled Digital at the Point of Care. So what we have now is, rather than us having to bring our own phones and our smart devices into hospital, we've got something that we can use, and we can use at the bed space, and we'll be able to move it around, and we should be able to talk to each other and be able to put notes on it and other things like that. So this is really a landmark step for our hospital here, that we've got lots of these available for us, and as Claire will show you, we've got them at the back of the wards as well now. We'll be able to use them for the future, be able to look after patients better, and conduct our business in a very different way. So tell you about that a bit more, here's over to my colleague Claire.
Hello, thank you, Justin. My name is Claire Richardson. When the Royal Surrey Covid-19 Action Plan launched in April 2020, I found myself redeployed overnight from my job as a bowel cancer nurse specialist to the relatives office and POCT team. I quickly realised how difficult it was for relatives to stay in touch with patients when all visiting had stopped and the strict infection control measures required were introduced. Knowing that family support is critical to the recovery of patients, I began to look across the wards to see what we were doing to keep them in touch with each other while ensuring that everybody was safe. I found that where they could, patients were using their own phones to speak to their loved ones, but not everyone had them. So we arranged a contactless property drop-off service to deliver phones and tablets from relatives, and I put out an appeal for spare phone and tablet chargers for distribution to the patients on the wards. Relatives continued to ring the wards and leave messages, but these were often lost in translation or delayed if the patient was in isolation. In some cases, staff were using WhatsApp to stay in touch with relatives, but there were concerns about privacy issues around their own and the relatives' data, not to mention keeping the wards and their own phones clean to avoid spreading infection. And it wasn't possible to use normal phones or tablets between patients, as they couldn't be decontaminated to the required level to prevent the spread of COVID. And it was quite clear that a piecemeal approach could not continue if we were to keep families properly in touch with patients while adhering to the strict COVID-19 measures. We introduced a number of initiatives to support communication within the Message to a Loved One service, which we launched, such as an email and photo delivery service to patients. So relatives could email in to a generic email address with photographs, and we would print the email and the photographs, laminate the photos and take them along to the ward. So people were delighted to see photos of their dog or their garden, and it really cheered them up. We had a Knitted Heart initiative where local people knitted matching hearts, and we gave one heart to the patient and one to their loved one at home so that they could feel connected during this period of time. And this did bridge a gap, but it was still second best to a visit. I liaised with our IT department, who had just started using these smartphones that Justin has told us about in ICU. The devices, which can be easily cleaned to meet the strict infection control guidelines, were enabled with a single sign-on system from Improvata, which was already in use on shared PCs in the Trust. And we also had a two-way video consultation technology from Attend Anywhere. And this was being used for the video outpatient appointment across the Trust. And so the idea for virtual visiting was conceived. I previously worked as a matron within the Trust on the wards, so I knew what would be required practically, and IT knew what was possible with the Trust infrastructure. As we would be using current technology within the Trust, it was already available, but there were only a couple of the smartphones available for the ward, which wouldn't be enough to implement this idea. So I decided to put in a bid for charitable funding, which I pulled together over a weekend. I emailed it to anyone I thought might approve funding, and immediately on Sunday morning I had a response and the support of the Trust's chair, and within days my bid was successful and the order was placed to buy one phone for each of the wards, plus our community hospitals, and virtual visiting was born. With IT support, we rapidly signed up staff on all the adult inpatient areas to conduct virtual visiting on the smartphones. The phone is taken to the patient for the pre-arranged virtual visit. The member of clinical staff can quickly, easily and securely sign into the phone with one tap of their ID badge with no need for passwords. It's very easy to use, so there's no specific skills required. Wearing gloves, absolutely fine, because we don't need to touch the screen, just touch our badge. The data is automatically wiped after each visit to meet the data control legislation, and patients can see and talk with their loved ones, who without this initiative they may not have been able to have any contact with. As they're designed for clinical use, the phones can be thoroughly cleaned after each use to the infection control standard required. Within a month, we've conducted hundreds of virtual visits on the ward, and we continue to do dozens a week, even though there are now some visiting opportunities. Virtual visiting has made a tremendous difference to patients and their families, and feedback has been overwhelmingly positive. It has maintained the human touch during the Covid-19 pandemic and beyond. Within 5 minutes of introducing it on one ward, a COVID-positive patient who hadn't seen his wife for 5 weeks or spoken to her was able to see and talk to her. Everyone was in tears, staff included. Another patient whose condition was sadly deteriorating had a virtual visit from his son, who told us that his father looked better than he had feared, and that it was reassuring for him to see him being looked after so well. Virtual visiting has reduced stress for nurses too. We all know that you can't comfort a patient in the same way as a loved one can, and many of our patients were alone in cubicles for hours on end. It has been particularly beneficial to our elderly patients, stroke patients, patients with dementia, who perhaps don't have their own phones or devices to have visits with their loved ones, and I'm confident that it has supported them in their recovery. Virtual visiting revolutionised how we organise visiting time, and although it was introduced to meet the need during a pandemic, it has continued, even as the restrictions have relaxed. And there'll always be relatives who live too far away or disabled without transport or find it difficult to get to the hospital. The wards are also exploring other opportunities for use. For example, virtual ward multidisciplinary and pre-discharge meetings, which family and patients often take part in. The trust pulled together, and technology that might have taken years to introduce was rolled out and embraced overnight by staff and patients alike, and it made a difference to so many lives. So I'd now like to hand over back to Dan Bishop, who will be chairing our question and answer session.
Well, thank you, Justin and Claire, for really interesting insights into how that technology was used for internal purposes, for our clinicians to talk to each other, and also, really importantly, for our patients to be able to speak to their loved ones, as we just heard from Claire. And I know, as having been an inpatient myself, I know just how important those family visits are, and to have been able to find a way where they can happen with all the infection control and isolation procedures, I think is marvellous. So thank you so much to Claire and everyone who's been involved in those. We have got some questions that have come in, I'm delighted to say. The first couple are for Katy, I think, if that's okay, Katy, because they're from the first presentation. So the first, and then I'll move out of the way, is, do the rapid testing labs need to be set up and run in a stable and controlled temperature?
Yes, I do, absolutely. Actually, the temperature control is far more important for the reagents, the actual tests themselves. A lot of them have to be stored in the fridge, and we have a monitoring system for those fridges to make sure the temperatures are okay. Interestingly, the first device we had, the DRW Samba, because it had been used in Africa for the HIV testing, is very tolerant of incredibly high temperatures. It can work quite functionally up to, I think it's 42 degrees. Far higher than the staff can manage. So yes, but generally all pathology devices do require temperature control.
Great, thank you. Sorry, Katie, I should have said that. I'm going to have a second one for you. We're just dancing around to maintain our social distancing here. The second question for you is there a plan to roll out these rapid testing labs across more sites, and will they be available to other users like pharmacies?
So we definitely have an intention to roll them out to wherever it is that our NHS hospital sites need to use them. The limitation on that currently is there is still limitation on the number of devices and the number of reagents that we're able to get into the UK. And working in my Department of Health, or rather my UK Health Security Agency role now, I know what a difficulty it is for us to get in sufficient reagents. And so we have to look across the entire board, and ultimately our highest priority from NHS England is to provide those rapid tests for our most urgent and acute admissions, which is for A&E. In terms of for pharmacy or other situations, there is some kit available out there, but we try and keep the most accurate and most rapid tests ultimately for A&E.
Thanks very much, Katie. One for Justin now, if that's okay, Justin. The question is, will virtual technology be used more extensively between GPs and the hospital in the future? For example, when discussing patient readiness for discharge or treatment requirements?
I suppose the answer to that is that we don't know, but the sky is the limit. Once you start embracing technology like this, we can do anything that we like with it, because we can liaise with the companies, both software and hardware, to be able to take things forward. There's no doubt that engagements with the IT structure here have said that we can potentially do some more things. So the hospital here is on the threshold of a big bang for IT anyway, with our new and forthcoming Surrey Safe Care electronic system. So to be able to use all the ready data at our fingertips and be able to interface with primary care, the GPs, and be able to have this virtual technology and so go over patient details is a potential future that would be fantastic to realise. Like I say, if we can think of it, ideally at some point we could be able to deliver it, and there's no doubt that we have the technology expertise in our IT department.
Thanks, Justin. One has come in for Claire. I think you touched on this briefly, Claire, but the question is, did you find that virtual technology was embraced by all of our patients, and in particular more mature patients?
Actually, interestingly, it was actually particularly beneficial to our mature patients who perhaps wouldn't have a mobile phone or perhaps be confident using that type of thing. So the micro handsets that we used in the wards would actually be taken to the patient. The nurse could stay with the patient during the virtual visit if they were unable to use it themselves. We also had volunteers at the time who would come to the wards and help the patients. Sometimes it was a little challenging for the visitor at home, the more mature visitor who perhaps wasn't used to logging on to things, but we would often talk them through the process. So we would talk them through from the hospital website opening page with a button on there, and then we would talk them through how to click into it, and it really was quite easy. And people, I think a lot of people surprised themselves because they were able to use it and perhaps didn't expect that they would. But of course, as with everything, it wasn't suitable for everybody, which is why we had our other issues and initiatives that we set up to help people communicate and feel connected with each other.
Great, thank you very, very much. One for Justin, not so related to technology, but a really good question. If I get COVID, says the question asker, where do I get sent?
Ah, okay. So if you get COVID and you're ill enough to come to hospital, then the first point of call, of course, is going to be our emergency departments. And what they're going to do there is they're going to assess and see how bad it is. Obviously, we hope that you don't end up coming into hospital. But if you're so bad, and one of the principal things is that you need to have ongoing oxygen to be able to make sure that you're able to breathe, then you're going to need to stay with us in hospital. The first point of care then is our new dedicated built Guildford Borough Council ward, as it's called, and where we've got specific isolation rooms where patients who've got COVID can be looked after in a safe environment so that they can be kept away from other people and not give it to other people, but still getting sort of dedicated one-to-one care in their own individual air-conditioned room. Although unfortunately, of course, people don't necessarily appreciate that because they're not very well. Hopefully, you don't get so unwell that you make it as far as coming to intensive care with me, because we only take the tip of the iceberg, as it were, the people who are severely unwell and make it through to intensive care. And we have a process of constant review to make sure that people are assessed, to make sure that if they do deteriorate, that we pick them up in intensive care with you to giving them our very strongest, best, most intense by definition treatments to make sure that they get better. So there's a spectrum, and ideally we hope that when people do come to our emergency department, they're not that unwell, and we can give some things to make sure we can go back and isolate at home and get better. But if they have to come to intensive care, then we have a great one to look after them.
Thanks very much, Justin, and to all to everyone that's answered those questions, and to those that have asked them. I don't think, I'm just looking over to my colleagues, there are any further questions. So it just remains for me to thank very much Jennie, Katy, and Justin and Claire for their amazing presentations today. Thank you to our comms team for making these events possible and making them happen behind the cameras. Thank you to you at home for registering and joining us today. I hope you found the presentations really useful and insightful. And tomorrow you can come back for the next of our members events if you'd like to. Tomorrow we have the title Supporting Services in the Community Now and in the Future. That will be a brilliant evening, and you can register now via the website. So thank you very, very much for joining, and a very good night to you.